Good evening. It's now 6 o'clock. I'm handing over to Dr. Matibula. Dr. Matibula, over to you.
Good evening, everyone. Welcome to our webinar, which is the last one for the year. And thank you for taking out the time for joining us. We really appreciate this as the Gauteng North branch. As you've seen with our ads and everything that's been online, today we are discussing two variable topics, which are men's health, as well as an apology in the medical field. These are two topics that are very difficult to attend to. And as a result, we've got two renowned speakers that will be giving us a brief overview as into how to approach them. One of our speakers is Dr. Franz Korb. Dr. Franz Korb has got quite an extensive resume, which will take the whole day if I were to explain it to you guys. But he's got a very good background in both psychology and psychiatry. And as a result, will be giving us a breakdown on how to approach this topic of men's health, as well as saying the apology. And our second speaker is Professor Brandt, whom is also well known to all of you, especially those in the undergraduate sphere, as well as the postgraduate surgery department. Without wasting any further time, I'd like to give the floor over to Dr. Franz Korb. And thank you for taking the time out to give us this talk. Over to you, sir.
Right, let me just get my thing started. I think I'm now online. Let me just share my right, it's there. Okay. Good evening, everybody. Yeah, I've been asked to talk about men's health in South Africa. I hope everybody can hear me. Is my voice coming through?
Dr. Korb, we can't see your presentation yet. I don't know if you started sharing.
I did. Let me just go back. Let me just do that. Okay, that should be there now.
Something is coming through here now, and yeah, in just in presentation mode, and then we're all good.
Okay, that should be it.
Perfect. Thank you, Doctor.
All right, so, okay, and my voice is coming through clear, eh?
Perfectly. Thank you.
Okay, thank you very much for inviting me. I mean, I'm actually quite honored. I'm on the board here of the Southern Gauteng, or the Gauteng branch in Johannesburg of SAMA. So I think it's really a pleasure to speak to my colleagues in Northern Gauteng. Not that we often meet together, but thank you for that invitation as well. And I've been invited through SAMA, and I think also because I'm a member of SADAG, the South African Depression and Anxiety Group, where I've been on the board and helping with SADAG for the last, since it started 31 years ago already. So I really want to speak about mental health, and what I really want to do is just highlight a few things. I think it's such a vast topic to cover in the next 30 minutes. So I'm going to highlight a few things, and I think there will be time for discussion. So hopefully we can get people to chip in and share ideas and views and opinions as well. So the whole thing about men's and mental health came up a while ago in the 2019, 2020 years. It started really with a big movement in the US, and they organized this big, what they called a landmark conference in Miami, with the title Behavioral Health Aspects of Depression and Anxiety in the American Male, which sparked a whole cascade of events and then publications after that. And I think the most important publication from that was the end of 2020, where editorial was written in the American Journal of Men's Health, with the title Male Behavioral Health and Suicide in America, Anatomy of a Growing Crisis, the Crisis in Male Mental Health, a call to action. And hopefully that call of action has been perpetuated up till today, and that is why we're having the seminar as well. And as you know, November is Movember, which is also a movement that started in Australia, initially with prostate and testicular cancer, highlighting that to the public. But last month was also World Mental Health Day on the 10th of October. So it's really appropriate to talk about all these things now. And in SADC as well, I've been also one of the champions to drive the whole thing about mental health in men. So let us look a little bit. I want to not give too much statistics, but in the next few slides, I just want to hopefully create awareness about the problem of male mental health and also mental health in general. This is a slide I took from the World Health Organization. They every few years do what they survey most of the countries in the world in terms of mental well-being of that country. The last report was published in 2022, which is only, 2-3 years ago. And I think at least there we are a first, because South Africa scored the worst worldwide in terms of our mental well-being in South Africa. And there you can see I've just screenshotted the bottom part of the graph, and here you can see South Africa was the worst worldwide, with just over a third of people in South Africa that surveyed were in severe distress and struggling. Interestingly, the UK just came above us with 35.7%. But showing that we as doctors need to be very much aware of the mental well-being of what is going on around us. One of the questions they ask, which I found also quite interesting, is they ask people if they will go for help or seek help for their mental health. And there South Africa is, you can see, fourth from the bottom. And just over 60% of people in South Africa said they're not going to go for help, which to me is another very concerning statistic, that the people don't feel comfortable going for help in terms of their mental health. The other stat from the World Health Organization are the suicide rates, and that is primarily what we often deal with at SADC on our helplines. The last statistic was done in 2019 worldwide, and there we also had the honor in South Africa that our suicide rate in South Africa is the 10th highest in the world. Southern Africa is not doing well. You see that Lesotho is the highest suicide rate in the world, and then Eswatini, Swaziland third, and then South Africa came in at number 10. If we then break it down between men and women, and I think this is now where the real big concern starts, is that men in South Africa are 5 times more likely to die by suicide than women. Again, highlighting the absolute necessity that we as medical practitioners need to be aware of men and get men to get help for their mental health. I've just put this is the American statistics, but I would like to just highlight the very bottom sentence there, that if you look at men's mental health, that men are up to 2 to 3 times more likely to abuse drugs than women, and also that in the US, more than almost 3 times the amount of men die annually of alcohol-related causes than women. So really just also highlighting from a substance point of view, the need for men to be identified, helped, and treated for these conditions. Last week when I was invited, I asked SADC, the researchers there, to give me some statistics about the mental health in South Africa and men. And what they came up with last week is that in South Africa, only about 1 in 10 people, that's the total population, 1 out of 10 people have access to treatment for mental illness. That means 9 out of 10 people do not have access to treatment for mental health. When you look at the suicide rate, I think that's from the MRC, it's estimated that in South Africa, we have about 23 successful suicides a day and 460 attempted suicide every 24 hours. So that also means for 1 suicide, there are 20 attempts. And I think the most important thing I want to highlight is that suicide, depression It doesn't discriminate against what your race is, your gender, ages, whatever. Everybody we see can be at risk of depression and suicide. I think the other big statistic that I find quite disturbing is that if you look at our Department of Health in South Africa, only about 5% of the national health budget is allocated to mental health, and the rest all goes to physical health. So again, a kind of a disturbing statistic for me. South Africa, the research which was published in the Public Health Journal 22, that about quarter of 25% of adults in South Africa suffer from depression, and the lifetime prevalence stats is up to about 30% of South Africans will at some stage in their life have a depressive episode. Okay, let us just go through the kind of main themes in terms of stress, burnout, depression, and suicide. And I want to highlight, because I just clumped them all together, because those are the most concerning aspects in terms of male mental health. Not that the other pathologies psychopathologies do not exist in men, but those are the important ones that we kind of deal with most of the time. That's why I just want to highlight it in this lecture. Stress is such a thing, especially now this time of the year. Here at my practice, I think in the last few weeks, I must hear that word stress about 100 times a day. That's end of the year. I'm stressed out. I'm burnt out. I had enough of this year. This year must come to an end. But when we look at stress assessment, it's really a vague, it's not a medical diagnosis, but I think we need to be aware of stress and how we assess stress. And I've just divided them there. Lots of those things fit into depression diagnosis. Lots of them fit into generalized anxiety diagnosis, all of that. But remember, there are physical symptoms that alert us to overly stressed people, like vague chest pains, fatigue, trembling, sweating, frequently having cold sores, flus, all those kind of things. The mental symptoms, the cognitive symptoms, decrease in memory, decrease in concentration, being confused, start being too serious, lack of humor, the emotional symptoms, irritability, anger, rage, feelings of anxiety, hopelessness, helplessness, all of those. And then the behavior symptoms that goes with overly stressed people, crying for no reason, fidgeting, increase in alcohol, increase in substance abuse, all those kind of things. So that in terms of the kind of symptoms that alert us to a person that's overly stressed. Now, the next thing is burnout. So if we don't manage stress, then stress will go over in burnout. And what burnout is, it's never been included really in the DSM-5, DSM-10, but in the new ICD, the ICD-10, the ICD-11, burnout now for the first time has been put in as a concept, as a medical concept. And I think you're all aware of the kind of three core symptoms of what burnout is all about. The first one there in red is that people describe this feeling of depletion of energy, that you're always exhausted, overwhelming. Exhausted is the first one. The second symptom of burnout is that feeling this increased mental distance, detachment from your job, losing interest, negative, cynical, that kind of thing. So it's exhaustion, detachment. And then because of that, the reduced professional efficacy, that you become ineffective, lack of accomplishment, the kind of thing which they call presenteeism. You're at work, but you're not performing. So that's burnout. Now, if you don't manage burnout, again, it's like a cascade. It then goes on to clinical depression. And the vast majority of 80% of people with burnout, if it's not managed, will go into depression. And with suicide as well, the next few slides, people that commit suicide successfully in kind of post-mortem, psychiatric post-mortem studies, at least about 80 to 90% of people that do commit suicide do have depression as well. That is why I'm highlighting the whole thing about depression as the primary psychopathology we're talking about tonight. Now, depression as well, I haven't put up all the criteria from the ICD and the DSMs, but again, there's the sleep, the biological, physical symptoms, sleep disturbance, fatigue, constipation, change in appetite, poor concentration, poor focus, generalized aches and pains, the psychological symptoms, the depressed mood, the anhedonia, all of that, and also never to forget the social kind of symptoms of depression, the social withdrawal, developing problems in relationships, losing interest in your sport, your activities, and that kind of thing. So getting back to specifically males and how males present, it's lots of written about it. It's never a rule that males present differently than females, but they might be kind of indicators in terms of the difference between males and female depression, where women turn their depression kind of inward. They blame themselves for how they're feeling, where men, if they feel depressed, they blame others, that external kind of focus. Men usually, when they become depressed, feel angry, irritable, this overinflated ego, nothing wrong with me, I can't be depressed, don't tell me that I've changed, don't tell me I'm depressed, that kind of thing, where women are more sad, apathetic, withdrawn, feel worthless. Men become very suspicious and guarded when they become depressed. They tend to create conflict, where women tend to avoid conflict. Men become restless, agitated, irritable, that kind of irritable depression that we call, where women becomes again slowed down and nervous and withdrawn. Men, when they are become depressed, they have to be in control at all costs, where women then have trouble setting boundaries. They easily will call a friend, go out with a friend for coffee and talk about their feelings and how they're doing, where men will do the total opposite. Leave me alone, I know what I'm doing, there's nothing wrong with me. Men find it weak to admit, and I think there our big problems come in, and my last few slides on how to manage comes in. Men feels weak and they're difficult to admit that they are depressed, that they feel desperate, that kind of thing. And men often then, to cover up or hide or cope with their depressed feelings, will then revert to alcohol, watch more TV, sports, self-medicate, sex, all those kind of things. So that in just vague terms, the kind of difference that we see between depression, how it presents between males and females. Obviously, when we manage depression, not only depression, any mental illness, psychiatric illness, we need to look at the lifestyle of the patients and advise them. Biological, we can give them medications to help, and then also the other things like ECT, TMS, all of that to help from a biological side. We need to always look at psychological factors. If their individual therapy, if their marriage has suffered through the depression, send them for marital counseling, all those kind of things. We can look at socially what is happening to the patient with depression. We can send them to an OT, which can help with vocational rehabilitation, social skills training, social skills reports. And then we've got the newest kind of treatments on the markets, the ketamine and all of that we can use. So really what I'm saying is that if you do manage depression, especially in males, and it's often in males, it's better to start with a biological. You know, if they come and see us and we immediately say, you are depressed, I'm putting you on antidepressants, immediately the defenses go up. But if one combine it with talking about lifestyle, biological, medication, possibly psychologists, let's get help for your marriage, let's see you're not functioning well at work, let's get you to an OT, let us see how we can help. So often seeing it in a total lifestyle thing helps with males to help with that as well. This is just a suicide slide, just the kind of warning signs, and I think this is very important in practice, in medical practice, and as well as that we need to educate the public on what are the warning signs of suicide. I'm not going to go through all of them in detail. When people start talking about suicide, of course, and starting to talk about wanting to hurt themselves, kill themselves, and starting to ask, is the firearm there? Do we still have bullets around? All of those kind of things. If they start talking or writing about death, dying, suicide, feeling hopeless, that kind of nihilistic feeling that life is not worthwhile, feeling rage and uncontrolled anger, irritability that often goes with the depression. If they start reckless activities, especially if it's outside their normal, if people start emotionally acting outside of what they normally do, if there's a change in their mood and it persists, one always needs to be aware of that there might be a psychological thing, especially in men, if they stop going to watch the rugby with their friends on a Saturday afternoon or that kind of thing. People talking about feeling trapped, increasing alcohol and drug abuse to kind of cope with those feelings, withdrawing, feeling anxious, dramatic mood swings, and seeing no purpose in life anymore. I've just put this up. There is this little scale which we can use called sad persons, which highlight to us that a person might be suicidal. And you can just write that down. It's called the sad person scale, and it's on the side there what it all stands for. Okay, in the last 10 minutes or so, let us just quickly run through a few slides how we can manage men's mental health. Now, in this one and in the next slide, I've got two aspects. The whole thing is still stigma. I mean, men and mental health, the whole thing about masculinity, what the gender, our society, our societal taboos is there, the kind of outdated ideas that the public has about what it is to be a man is still one of the stigma, and all research over the years up till now has very much indicated to us that stigma is still one of the most important things in male mental health and trying to break down. And I mean, like I say, I've been with SADC since it started, and this is still when we try and deal with men and mental health, depression, suicidality, feeling suicide. Stigma comes up all the time. So, you know, that first sentence, the second thing is, and we've still got in this modern day, and it's not only in South Africa, it's worldwide, this kind of stereotype, what must a man be like? This kind of stereotype of what is masculinity. You know, that men are supposed to be strong. They're not allowed to show emotions. You must be unemotional. You need to be self-sufficient. Don't let somebody tell you you've changed, your mood is depressed or your mood has changed. You need to go and see a doctor. You know, that kind of thing. So it's this kind of unhelpful stereotype that we need to still break down. And I think the other thing is also this kind of a perception in terms of stigma that's out there that, you know, mental illness is actually a sign of weakness. You know, it's not. A mental illness is an illness. It's a medical illness. We now know so much about the psychopathology and our pathology of all the psychiatric illnesses, from anatomy through to brain pathways to neurotransmitters. We now know so much about these things that we can really honestly say that any psychiatric illness is really a medical illness with a good medical foundation that we need to treat. And of course, we know that men that lives in a society with these kind of stigmatizing aspects that I've just mentioned are more at risk of developing stress, burnout, depression, other psychological issues, suicide, and that kind of thing. So stigma is still the most important thing in terms of dealing with men's mental health that we need to deal with and break down. The other two things that is important is the lack of awareness, the second aspect of dealing with men's mental health. And that is really the kind of knowledge we have out there about what mental health and mental illness is all about. The slide I had about the possible difference between a male and female presentation in mental illness. Ultimately, it's the same thing, but to be aware of it at times. And also, I think we need to shift away again from this thing that, you know, it's not a weakness. It's actually, if you go for help, it's actually a strength if you recognize that you are depressed and you go for help. And also, we need to educate the public out there that any mental illness ultimately is a treatable condition, and that we these days do have good treatments that we can treat people with. That mental illness is not this hopeless thing that there's nothing we can do about it. And the other thing we need to be aware of, that for men it might be very hard or very difficult to recognize that they are depressed and that they need help. And that it's when they, like I said in the previous slide, when you do suffer from mental illness or that you are depressed, it's not that you are bad, but that you need to get help. Yeah, and men often also, in terms of what we come across, is they feel that if they ask for help, if men feel that they ask for help through their family, their wife, their spouse, the doctor, that they're going to be a burden. I'm going to be a worry for the family. I'll be judged if I ask for help. So again, we need to be aware of that we can kind of in a supportive way open up discussions that if you ask for help and we get you help, you're not a burden. You're actually more of a burden to us being depressed than if you go for help. The last point there is a kind of a difficult point, the need for reciprocity. And often men will go for help in terms of you tell them, if you go for help and you feel better, the whole family will be better. But in your bad emotional state at the moment, the family will not get better, or that you're more of a burden or a kind of it's more negative on the family in your current emotional state. So if you go for help, things will be better, and the whole family, the marriage, everything will be better. So that in terms of the kind of background of dealing with mental health. I just put this slide in for stigma as well. Like I say, there is such a lot written about stigma. And stigma, there are two definitions there from two resources that I use. The first definition is that mental health stigma is an umbrella term, of course, and there are 4 kinds of stigmas that we need to be aware of. The first one is social stigma or public stigma, the stigma that the society you live in place on you. There's self-stigma, that's how you perceive yourself, that if I suffer from depression, I've got a weakness. Then there's professional stigma, and that comes from, hopefully not so much anymore, our medical practitioners, that we don't want to deal with mental illness and that kind of thing. And then there is lastly cultural stigma as well. So all of those kind of 4 types of stigmas. And then that last definition I find quite helpful as well, that mental health stigma can be understood as the combination of a lack of knowledge, so people are ignorant what it's all about, negative attitudes about mental illness, prejudice, and then the third one, disadvantaging behavior, discriminating against people with mental illness. So that just as a background, I mean, I think we can have 2 hours just talking about stigma and everything. Okay, in the last 2-3 slides, before my time is up, perhaps how we can help. The first one in the workplace, and the next slide at home, or what we can do about it in a personal capacity. So in the workplace, and often we at SADC do go out to mental health or health days at companies and corporates. And what we need to do in corporates as well is encourage men to talk about mental health in a non-judgmental way, encourage ongoing self-care, and set an example that hopefully now most of the big corporates and companies do include mental health in their wellness days. We need to talk to men about the language that they understand and resonate with them, instead of saying you need to go to an OT or you need to go to a psychologist that immediately gets their backs up. Say, can we rather say, let us get you a person to self-help programs, rather talk about coaching than psychotherapy, or let's rather say, let's rather try and build your skills rather than therapy. So those kind of language that resonate with men we need to use. The next one, provide mental health benefits. That is really in terms of the benefits on medical schemes and help there. Confidentiality in men that they, and I think that is often again, that links back to stigma. If people at work knows that I've seen a psychiatrist or a psychologist, or I'm on an antidepressant, immediately that is going to put me in a very bad position in terms of progressing in my career ladder, all of those kind of things. So from our HR point of view, to do that. And like I said as well, build a culture of mental wellness at work. Look at the company culture of work, safe, psychologically safe working environments, and again, education and training of managers. I think that is also important because so often I get my patients here at the practice as well, where they say that I told my manager I need some time off, or the morning off, to go and consult my psychologist. And since then, the relationship between me and my manager has been very strained, and they've got this idea that I can't do anything and that kind of thing. And then also in the workplace, the different needs of different kind of subpopulation groups, race-related stresses, the LGBTQIA community, cultural views on mental health. So all of those kind of things that we need to understand. Then just at home, what we can do, I think we need to educate, keep on educate. And that is what we do with SADC, with our website, with our groups, without going out, educating, sending out pamphlets, teaching people as much as possible about mental health. So education and support. If we keep on talking about it at our homes, that people can see we can openly talk, and that men can see we can openly talk about it, understand it, not make a joke about mental health and mental illness. That will also put men more at ease to go for help. And like I've said a few times, that to go for help is a sign of strength and courage, not a weakness. Schedule an appointment. Men in the first appointment often is very, very reluctant to go. And if the wife says, I'll go with you, let's both of us go and talk about everything. And let's go and talk to the GP first. And then if the GP do send us to a psychiatrist, let's talk about it. And let me come there, let me go with you, let me support you, let me add in, let us make plans together. Often that helps in getting men to go for help. And then, of course, the partners also need to know that they need to look after themselves, because often men go late to get help. So there's already been a lot of burden, a lot of kind of negative things happening in the marriage. And then there are things like support groups and that kind of thing as well. Okay, so just in summary, need to remember that mental illness is common, like I showed you on those first few slides. To also emphasize again that mental illness is a medical problem, and it should be managed properly, medically, psychologically, psychiatrically, with psychiatric medication. Mental illness in men is very prevalent, and it should be recognized and again managed. It's got a significant impact on men in terms of their functioning in all aspects: work, home, relationships, marriage, everything. So a screening in our medical practices is very important for mental illness in men, even when they come. I mean, if they come for their annual blood pressure and cholesterol checkup, I just put in a question: how have you been feeling lately? What has your emotions been lately? How's things been at home? How's your marriage been? How's things going at work? Just putting those kind of subtle questions in as well when we see men with that. Depression is lethal, and suicide is lethal in men. Please always remember that. And then the appropriate management of mental illness in men should always be a priority. I've just put in this last 2-3 slides as well. I know this is a medical meeting for medical practitioners. At SADC, and together with the Healthcare Workers Care Network, is a network that started with the start of COVID to look after the mental health of our colleagues. So please be aware of it, that there is the Healthcare Workers Network, and that is for all medical practitioners, actually for everybody. It's not only for medical practitioners, but for pharmacists, for dentists, for nursing staff as well. And there are the numbers, 24 helpline for that. And what also the Healthcare Workers Network do is, besides that, you can get support, individual counseling, and I think there's a few free sessions with psychologists through the network. And they also run support groups. And interesting, this Thursday, the 27th, there's an online Zoom meeting, free support group meeting for healthcare workers, for any of us and our colleagues that might need to help, they need to get help and talk about it. So I've put in there just lastly all the SADC. You don't have to write that all down. Perhaps the main one is there to go to the website sadac.org, and you'll get all the numbers there, the suicide lines, the help groups, everything is on there. So I think, let me stand there. I think, yeah, 5 minutes over my time. Let me just exit here. And I'm happy to answer questions. I'm happy to have discussions. And hopefully with this presentation, again, just highlighting the importance of mental health in men, and perhaps just this last slide as well, to also all my colleagues, that we also need to look after ourselves, and that then we must also support our colleagues as well. Okay, let me just stop there and go out of the presentation there. Okay, hopefully that gave a bit of an overview. I must now hand back to the person that's running. Okay, Dr. Matabula.
Thank you very much, Dr. Korb, for that enlightening presentation. I've got quite a few questions of my own, and I will also have a look at the chat, but I think it will be worthwhile if we ask all the questions at the end. I hope you do not mind.
No, I'll be online.
Okay, so then I would like then for Prof. Brandt to come into the podium to then just give us an overview as into how we should be handling the apology side of medicine, as it is one thing that most of us grapple with, as we are not really taught much about it, but it's something we have to deal with almost every day in our careers. As you guys might know, Prof. Brandt is head of department or head of unit at the University of Pretoria in the HPB General Surgery Department, but also has got a lot of work he does with ethics as well as MMed write-ups. Over to you, Prof. Brandt, and we look forward to your presentation.
Great. Thank you very much, Dr. Matabula, and thank you very much for the invitation to give this presentation. I'm going to share my screen quickly. And there we go. You should be able to see my screen. And there we are. So yeah, as you rightly point out, this is something that we really don't ever address in medical school or in specialist and subspecialist training. And it is something that is very difficult, and hence the need for this presentation. This is just a bit of marketing, but I think in that last column where it says MPS's philosophy is to support safe practice in medicine by averting problems before they happen. This is one of their presentations in the series. And this one actually addresses when something actually has already gone wrong. How do we address it then? So before I begin, really, did you know that there is a YouTube genre which is called apology videos? And what's interesting, before I go actually into the apology video there, what's interesting is that these videos were created to apologize for controversies by people who posted YouTube content. For example, they maybe had a large group of followers, and then maybe they posted something that their followers did not appreciate, or they even became a little bit hostile because they really didn't like what that person was posting. And so these have actually become strategic tools that are actually damage control. And so in a way, I think that this is what I'm going to be doing with you today. So I'm going to play you a very short video of quite a well-known YouTube apologizer. So let's see, hopefully this will go through nicely for you.
We're not here to judge. I mean, we are judging, we're just not here to do that. So fear not, you wrongfully accused scallywag. We are offering today 13.5 tips for making an absolute banger apology video for when you inevitably get caught, cancelled by your audience.
Okay, so we're not going to go into, hopefully, so much emotion like that lady did. I would like to start with a case study. This is actually a real case study. Fortunately, not from South Africa. It's an American case study. So JM is an 11-year-old boy. His sport was basketball and he loved basketball. And one day he came home and he was quite sick. He had fevers and he was complaining of a lot of pain in his ankle. In the next 2 days, his mom took him to see 3 different doctors, and they all had different types of ideas of what was going on with him, but he just wasn't getting better. So eventually his parents took him to hospital, and he was admitted, and he actually went to theatre that same evening for an incision and drainage of his ankle. He passed away the following day. So it really wasn't a very good outcome at all. So 8 years later, in the New York Times, his mom wrote an editorial, and I actually want to read this for you. I am still waiting for and still need that conversation. Not receiving an apology and explanation from someone caring for your child when something goes wrong is incomparable to any form of inhumanity in medicine or in society. It is simply not right. Justin was our child, and we were owed an explanation and an apology. We didn't expect anyone to say, I'm sorry that I screwed up. But perhaps simply, I'm so very, very sorry that your son has died in our care. I will do everything in my power to help you and your family heal and explain to you everything that I honestly know about the event. Justin's surgeon would have been my hero if he said that to us. But instead they said, these things happen in medicine. And we were expected to accept that. As a parent, I couldn't. So clearly, this lady is very much looking for an apology. And I think we'll be coming back to this a little bit later in this presentation. So an apology is an expression of empathy, where empathy is the ability to understand and share the feelings of your patient. It is very different to sympathy, where sympathy means feelings of pity and sorrow for someone, especially if they've had misfortune. And in the medical context, if you start using sympathy, it's probably going to be coming across as being very condescending. What an apology isn't, it is not an acceptance for the legal responsibility for an adverse outcome. And I think this is very important to realize. And I think this is one of the major drivers of people avoiding patients or patients' families when an apology is necessary, for this fear of litigation. There are always 2 sides to an apology. So there's the human side, where an apology is an act of empathy. It's also building trust. There's the science side, where there's a psychological impact of an apology. It affects patient satisfaction and compliance. And we must realize that patients and families experience harm from a harmful event itself. And they can experience what's called a secondary harm from how this event was handled at the time. A lot of patients actually say that the impact after an adverse event, if it wasn't managed correctly or appropriately in their perception, is that they have anger and vivid memories that can actually go on for a very long period of time after that event was passed. So when do we actually need to apologize? So there's 3 main scenarios. One is when there's obviously an adverse event. Second is if there's miscommunication between the healthcare provider and the patient. And then also unmet expectations, because our patients obviously might have conceptions of what they expect might be the outcome. And then obviously they might be upset if they didn't have that outcome. And again, that might just be purely through misunderstanding. So the ethical principles that we see when we do an apology is that we actually respect a patient's autonomy. We are honest and we provide transparency. We have a professional responsibility, where here responsibility refers to the state or the fact of having a duty to deal with something that has gone wrong or having control over someone else's situation. By doing an apology, we actually practice beneficence and we are practicing non-maleficence. We are also practicing justice, where justice is the quality of being fair and being reasonable. And we're respecting our patients. We have a respect for their feelings. So the medical legal concerns with apology is the fear of admitting a liability. It's the impact of litigation risk. And in many cases, it's wrongly believed that an apology actually opens you up to more risk. And the role of disclosure policies, depending where you are. This is a really interesting study where they actually looked at why people sue doctors. And it's a study where patients actually had launched civil litigation cases against healthcare providers. They were able to get responses from 301 plaintiffs. Of those 341, only 15% were given an explanation for the adverse event for which they were being sued within 2 days of that event happening. So in other words, it's a very long period of time before someone comes along and says, this is what actually went wrong. In total, less than half ever received an explanation. Responsibility was partially or fully accepted in only 10% of cases. And empathy was given in only 42 cases, which is approximately 15% of cases. So you can already see these plaintiffs really did not have much communication about what was wrong and who was responsible, and even just having plain empathy. So the three main factors from this study that came up that was a risk factor for litigation was accountability. Patients or patient's family wished to see staff disciplined and called to account for what went wrong. They wanted an explanation, okay? And a combination of wanting an explanation and feeling ignored or neglected after the incident culminated in litigation. And the third main factor was standards of care, which is very interesting for me that they actually wished to ensure that a similar incident did not happen again. What we don't see there is compensation. And compensation came very, very far down the list. So why do we hesitate to apologize? Well, we feel a perceived loss of authority. We're also uncertain about how we should word that apology. We're really scared that we say the wrong thing or we carry the wrong message. And of course, as I've said on multiple occasions now in the last few slides, there's a significant fear of lawsuits. However, there are significant benefits to an apology. There's actually reduced litigation, and there are several studies that have shown that if one apologizes and gives an explanation, that you are less likely to be sued. We actually have better patient outcomes because they are in a better space. They're more positive. They're more likely to work with the medical team, whereas opposed to a situation where they've actually completely lost trust and faith in the medical team. And because of all of this, there's an improved doctor-patient relationship. You actually don't lose your authority. You actually gain authority. So the art of apologizing. What are the elements of a good apology? Well, the first one is to acknowledge that something actually went wrong. One has to be empathetic, not sympathetic. One has to provide an explanation where it's appropriate, and one must always demonstrate a commitment to improvement. It's showing that you've taken on board what went wrong, one is looking into the reasons for what went wrong, and one is going to do something so that in the future it doesn't happen to other people. What we should not do is avoid with vague apologies. Don't acknowledge that something went wrong, not empathetic, minimal explanation, and no commitment to improvement. Don't shift the blame. Okay, because that's always where trust then becomes an issue. And you know that yourselves, if you go to a shop and maybe you bought something and when you got home it wasn't working, so now you take it back for a refund and you find that same salesperson and now they start shifting the blame, you automatically start trusting them a lot less. And don't minimize patients' feelings, okay? Never ever say things like, it's really not that bad, or it could have been a lot worse, because that really doesn't help the patient. So how should we apologize? So the first thing is to prepare beforehand. This takes a lot of thinking, etc. So don't run out into a situation without having thought about what you want to say. If you know the patient or you know their family, you already have an idea of what their reaction to this may be, what kind of questions they're going to ask. Prepare answers for those questions. Acknowledge clearly and honestly what went wrong. And I'm going to go through some examples after this. Take responsibility. We're not saying take liability. Take responsibility as the team leader for what went wrong. Show empathy at all time and always be understanding. Offer an apology. Explain without giving excuses. Okay, again, when we start hearing excuses, etc., one starts asking, well, why didn't we do something to prevent whatever the issue was? You start losing the trust in the person who's actually giving you that apology. And then make amends and plan for improvement. Show that you've taken on board, or the system has taken on board, or the team, that something went wrong. We've investigated, or we are investigating. And once we know what it was, we will then put measures in place so it doesn't happen again. And then when you're done, invite questions. Don't run away. Let them ask questions and respect their responses. Often it will be very angry. And the answer to that is you understand that they're angry. And if they don't have questions at that point in time, always go back on another occasion and say, do you have any more questions? Or do you have any new questions, etc. So some practical phrases to use. I am sorry this happened to you. I understand that this has been difficult. These are two very powerful statements. And then at the end, do you have any questions or concerns you would like me to address? Always keep in mind, there are non-verbal aspects to an apology. Your tone of voice. You cannot be condescending. You cannot come from a higher pedestal. You have to speak normally. And your body language is incredibly important. Always try and maintain eye contact. Sit down with them. Don't stand if they are sitting, etc. Be at their level when you're doing it. Eye contact, as I said, is very important. So if we go back to what that mom said of Justin, I'm so very, very sorry that your son died in our care. I will do everything in my power to help you and your family to heal and explain to you everything that I honestly know about the event. So in other words, all the aspects that I've just mentioned, there's an apology, there's an acknowledgement that something went wrong, you're being transparent, there's no excuses, etc. It's exactly what she wanted. So the acknowledgement, someone to take responsibility, empathy and understanding. Note there's no sympathy in what she was looking for. An apology, an explanation without excuses, and someone to make amends. So here's an example of an apology. So this is another short video of a gentleman who may be a little bit irritated.
Go. Have a seat.
Finally.
Sounds like you're feeling a bit frustrated.
Dr. Miller, I've been waiting for over 2 hours.
Mm-hmm.
So maybe a response here that the doctor could have given is, Mr. J, I owe you an apology for keeping you waiting so long today. I know your time is valuable and the delay was frustrating. I should have updated you sooner about what was happening, and I'm sorry for not doing so. We'll make sure to prioritize your next appointment so this doesn't happen again. In addition, I'll work with the team to improve how we keep patients informed about delays. Thank you for your patience. Is there anything I can do right now to make up for the inconvenience? So this is really an absolute model apology. So there's an acknowledgement that the patient was kept waiting long. The doctor is clearly taking responsibility for this. He's doing it in an empathetic and understanding manner. He has offered an apology. He's actually said he is sorry. He's offered an explanation without giving excuses. And he's given a lot of information about how he's going to make amends, not only to the patient, but also to other patients in the future. So this is really a very good model way of doing an apology. I think I have a few minutes. I'm going to go through this example as well. So here is a patient who had an adverse event or a side effect for a new medication that was given. So Mrs. S, I want to apologize for not explaining the side effects of your medication more thoroughly. I realize this left you feeling unprepared and anxious when they appeared. That was my responsibility, and I am truly sorry. Moving forward, I'll ensure we go over all possible side effects carefully before starting any new treatment. Do you have any questions or concerns I can address right now? So again, a very good example of an apology. There's an acknowledgement that something went wrong. There was a side effect from medication that was unexpected. The doctor is taking responsibility doing it with empathy and understanding. They've offered an apology, I'm truly sorry, and an explanation without excuses, and they've made amends, and also, again, giving an opportunity to ask questions. So again, a very good example. So in conclusion, when things go wrong, patients primarily want two things. They want an apology, and they want a reassurance that steps have been taken so that the likelihood of something else similar happening in the future again will not be repeated. My last few words, here are a few tips, for effective apologies. So when deciding how best to address issues of responsibility and accountability, if it really is a significant adverse event and you're very worried about it, seek early support and assistance from your malpractice insurer. Okay. For example, I'm well aware that MPS always has someone on a hotline who can give you support. So there's no reason why you cannot, if you were, for example, in an operating room, something went wrong, just walk out into a side room and phone them and explain what happened and ask for advice. And part of the advice is, how do you go out and speak to the family members who are outside, or how do you go and speak to the patient when the patient has recovered from their general anesthetic? Be sincere and be timely. Don't let this hang. You remember that study that I gave you where less than 15% of people were told within 48 hours of the event. You can be timely. It does not need to be immediate though. Let the dust settle and then go do your apology. Focus on the patient's experience rather, and separate empathy from liability. An apology does not mean you're liable for an error if an error actually did occur. And allow time for reflection. And again, that reflection is at the end where you give them an opportunity to ask you questions, but also to say, you know what, I know this has been a big event, or this has affected you severely. Let's meet tomorrow afternoon in my rooms again, and I'll be more than happy for you to ask me questions. So follow-up actions, always do follow-up communication. Patients really do appreciate this. And if I can give you also a piece of advice with that, is always document that you've done this. Document that you've given an apology, who was present, what was said during the apology, and then also document when and where you did the follow-up communication and what was discussed. And then, of course, reparation. Last words. There's always a second victim when there's an adverse event. And that second victim is the healthcare worker. Healthcare givers are especially likely to be deeply affected by adverse events, especially if they are serious. Following a serious adverse event, caregivers often feel isolated and will often experience profound shame and guilt, which one really shouldn't do. They can result in long-standing and detrimental impact on a clinician's ability to provide patient care. So the steps that should be taken: if it's a team, there should be a debrief of the adverse event. Provide support. We are all colleagues. We've all had adverse events. We all know how bad we felt at that time. If you know that a colleague had an adverse event, go up to them in a quiet moment, not in front of a lot of people, and say, geez, I'm really sorry for what happened. Is there anything I can help you with? Do you want to go for a chat? Do you want to go for a cup of coffee? Do you want to go for a beer or something like that? Be there for your colleagues, because one day you may need that support as well. And if they really are suffering under this, it may be necessary that you reach out to maybe whoever their close support system is and to say, you know what, I am actually concerned about Martin Brand. You know him better than I do. Maybe you should go and have a chat with him and see. Maybe he needs some help. So that's the end of my presentation. Thank you very much. I would just like to show, MPS is also launching a series of well-being seminars. They're for free for members of MPS. And again, it's got a lot to do with burnout, how to deal with it, and also how to be resilient in your practice, especially when things go wrong. So yeah, thank you very much. I'll stop my share and I'll hand back to Dr. Matabula.
Thank you, Prof. Brandt, for that. It was a very enlightening presentation. Let me have a look. I see we only have one question. I don't know if you guys can see more, but I think I'll start with my questions, if that's okay. And the first one is to Dr. Cole.
Yeah.
Thank you once again for the presentation. I made a few notes here, and what I actually picked up, which was a little bit scary, was the fact that 1 in 3 people will have a mental illness or present with a mental illness. And
In
I
a
mean,
lifetime. Yeah.
if you look around the room, then you're like, okay, that third person could actually be myself, which is worrisome. And then the other one was that 80% of suicides are men, which then brings us to why we actually had this topic as into like men's health. And I think you actually rounded it up in such a way that how I understand it now is that men's physical health is actually linked to their mental health. And what you said was that this boils down to stereotype and stigma. Now, and you said how to approach it is to speak the man's language. I'm a woman. How do I speak to a man in a man's language? Because that's one thing that I find very difficult to do, whether it's a man in my personal space or a man in my work environment or a man in patient-wise, like patient-doctor kind of relationship. So like how does one establish that? How do I even start that conversation to actually say, listen, Dr. Kopp, I've observed 1, 2, and 3 with you. Do you think it's time to see a professional? Like how do I do that in a man's language? That's my question too.
I mean, it's a complicated question, and obviously men also differ from men to men, and one needs to kind of also know the man, which is difficult in a medical practice because you don't know every single man and every patient off by heart. But I think the main thing is again with the stigma, and I think it has got to do with that one slide I showed about what is masculinity. You know, that men is the hard one. I can't show emotions. I cannot have depression and that kind of thing. So I think the first thing is to what I mean with language is not to sit down and say, you've come to me, you've told me all these symptoms, you've got depression, you need to go on an antidepressant. So, you know, that is what I mean is that kind of direct language that kind of speaks to the stigma that I'm weak, that kind of thing. So one needs to avoid that kind of feeling that when you do discuss the diagnosis or treatment with them, that you're not going to get their defenses up immediately. Rather say, you know, speak that, you know, some people go through a difficult time in your life. And when you go through a difficult time in your life, and you've been retrenched or whatever it is, it can lead to some changes in your emotions. And when you do have change in your emotions, it can lead to ultimately, from a medical point of view, with a diagnosis. I usually use the term clinical depression. I know that the textbooks say major depression is the official term, but I think clinical depression makes it more medical and makes it not less of a thing that it's a weakness. You know, it's that kind of thing. And instead of saying, and I know that from all the men that I see in my practice, is that if I tell them you need to go and see a psychologist as well to sort out all your psychological issues, then the first thing they say is, do you think I'm mad? So, you know, avoid that kind of thing. Speak to them and say, I think there are lots of issues you've got from your childhood, or you've got problems with, you know, to take examples from they say, you're always fighting with people. You don't, every time you frequently change jobs because you don't get on with people. Don't you think we should send you to somebody who can help you look at what is happening in your relationships so that the person can help you and not just say, I think you need to see a psychologist, you need psychotherapy. You know what I mean? That is what I mean with using the appropriate language. I mean, there are men that are, I don't want to say enlightened, where you can say, listen, you suffer from depression, you need to go on to medication. So, but that is what I mean is that one needs to know the person you are speaking to. But I think to start off with, it's better to use that kind of language in men. I hope that helps a little bit to put it in perspective.
Does help a bit, because in my head I was just thinking, I'll be like, listen to it, let's go grab a beer and have a chat.
Well,
So your approach is much
the doctor,
simpler.
the doctor can't do that. But yes, I mean, if a man is depressed and they just bluntly refuse help, the wife can always get the person's best friend in and say, listen, and by that time the person's best friend would know that they might be depressed as well. And say, listen, I think the person is depressed. Take him out for a beer, go and have a chat. And in your normal chat, whatever you do in the pub, start talking about his emotions and how he's feeling and that kind of thing. So yes, you know, I suppose what I'm saying is to try and put you, and I think that's what we need to do as doctors, as always, is put yourself into the patient. That's what empathy is. Put yourself in the shoes of the patient and just try and understand how that patient perceives things, views things, his kind of philosophy on life, whatever you want to call it. And I think that is so wonderful, beautiful, that previous lecture that Prof just gave it. I think that's we must get him to talk more at our meetings, because I think apologizing is something, again, that men don't do. You know, like he said, it's blame. I think that was so brilliant, that talk, Prof. Brand, that was so good, is, you know, emphasize with the patients where there has been a trauma or whatever, put yourself into their shoes to understand what they're going through and apologize. I think, you know, it's all kind of the same theme. I'm talking too much, sorry.
No, it's very much welcome. Trust me, it is. We seem to have one question in the Q&A, and it's from Dr. Brenda Bega-Chauke. She asks, do you think the level of gender-based violence in South Africa has a link in unmet mental health needs in males? If yes, how can this be addressed, especially in the public sector, which serves approximately 80% of the population, where the need far outstrips the capacity?
Yeah, I don't think I should let myself out on GBV, on gender-based violence, but I think, you know, GBV is such a massive topic. I think, again, with GBV, to understand the cause, the origin of what GBV is all about is very difficult. I think there are psychological issues involved there. There are societal issues involved in there. There are cultural issues involved in there. So, I mean, the GBV is a massive, massive problem in terms of understanding and dealing with it. Certainly, mental illness, or should I say, in terms of tonight, masculinity does play a part. Perhaps the kind of issue, you know, in terms of masculinity, that men perhaps, you know, one hand, men that do GBV feels in terms of a relationship that they are demasculinized, that, you know, I think when I listen to patients, that often happens where patients say that, you know, my wife don't respect me anymore. They say they can do it, and I'm the head of the house. I take the decisions. They're not supposed to take the decisions. So I think, and in a certain aspect, masculinity, or the view of masculinity, must have a role as well. But I think it's much broader than that. I mean, GBV is a thing that I think the sociologists must teach us much more about. Yeah.
Okay, I hope that answers Dr. Chauke's question.
Yeah.
From my
no
side,
simple.
that's all. Is there any other? Let me see. Okay, there's another one here, but I think this one is addressed to Prof. Brandt. How should practitioners manage patients' requests to waive professional fees following a complaint about long waiting times or an adverse event?
Yo. Financial question. Thank you. And thanks for the kind words, Dr. Korb. Yeah, as I said, an apology is not admitting liability for something. And if you've rendered professional services, you're entitled to be reimbursed for your services, even if there were an adverse event. It depends what aspect we're looking at. If we're looking at the surgical field, there's always going to be, hopefully, well, not always, but hopefully informed consent. And part of that consent process is always going to be discussions around potential complications, etc. If that happened and was in place and an adverse event happened, then the patient was informed, the service was rendered, so you are still entitled to claim your professional fees as such. So I don't think, in my personal opinion, I don't think one should be waiving fees, etc. Long wait times, I'm not sure how that's falling in. I mean, if it's a long wait time because there's a lot of patients in the waiting room, etc. Again, an apology, but if you saw the patient, you consulted the patient, maybe gave them a prescription, you are entitled to your fee. Maybe you had an emergency early in the morning. And again, that's where the apology comes in, is if they do come, what they are looking for is an apology. So what one can do, and that maybe speaks to that example I gave you, where that irritated patient was who'd been waiting a couple of hours for the general practitioner to come. It's just to give an explanation, to say, I'm sorry you had to wait so long. I had an emergency in the ward, which I went and dealt with. So unfortunately, I started an hour late. Unfortunately, I did not communicate that with our secretaries, so they did not push back the diary by an hour. So that is why we have a backlog. But if you still consulted with the patient and dealt with the patient, you are entitled to your professional fee. I would not waive it. You've still done your job, even though maybe the patient had to wait an hour or two later than what they were expecting. I hope that answers your question.
Well, it was not my question, but it answered a few of my own, because I must say, I think a lot of us have had those experiences whereby we've had to apologize to patients about waiting times, but somehow they expect us to not charge them for the consultation. So, yeah.
It's not fair. I mean, you still pay your plumber. If the plumber comes 3 hours late and the geezers run out of water, you still pay them, and very often you pay them in cash. So why should we as medical practitioners be any different?
Yeah.
If only it were that simple, Prof. Brandt, because it's always the comparison I make to them. I'll be like, when you call out an electrician, you pay a call out fee. Whether they fix your problem or not, you are still going to pay them. It's the same for the plumber as well. You pay them for just coming out. Whether they fix that geyser or they change that pipe or they unblock that toilet, that's something on top, over and above having waited. But for some reason in medicine, the doctor can't be late. The
No,
doctor
exactly.
just must not.
But I think that's where the art of apology comes in. And then if they really are adamant, I think one then has to say, well, is there something in my consultation with you that did not satisfy you? So that you can hear. And if they say, no, I got the prescription, I'm happy with the antibiotics. And you say, okay, so I've delivered a service to you, so I unfortunately have to be paid for my services. I can't go without. And that's pretty much where I would leave it. Because the problem is, if you start bending your knee once, then next time they come to your rooms, now it might be 40 minutes late instead of the hour and a half that it was previously. Now they're going to say the same thing and have the same expectation. So you can't set that precedent either. You have to unfortunately be firm, which is, I think the ugly side of medical private practice is the financial side of it, where people are asking for discounts or even asking not to pay, etc. It's a difficult place to be. But again, if you have a practice manager, if after you've spoken to the patient and etc., and they're not happy, then you say, you know what, here's the practice manager. Would you please deal with him or her? And then that's what part of the role is of the practice manager, is to deal with that.
Noted. Thank you very much. And then I have just one question. I know you said apologizing is not an admission of guilt by any way, but you also then said, before you go and apologize, take a moment, sit, prepare in a way as into what you're going to say, how you're going to say it, and, you know, have some answers, already set answers in your mind, considering what might have happened. But will then that not be seen as having rehearsed what you are going to say to the patient or the family? And then will then that not be construed or mistaken as trying to hide certain facts and as in a way be an admission of guilt?
No, I don't think so, because you must remember, I mean, obviously, the more severe the adverse event, the more the emotions are going to be there. And that is always the challenge, is managing emotion as such. So you yourself can't be emotional, and to minimize your risk of becoming emotional and distracted is to actually prepare very well and to predict what they're coming out and saying. So in my mind, the more severe the adverse event, the more time you need to actually sit down and actually plan what you're going to say. Think about what went wrong. Think about what went wrong. Why did it go wrong? What were all the factors that were involved? And how can that be improved going forward in the future? But what I also say is, the more severe the adverse event is, you really do need to let the dust settle, but you cannot run away. So what I find is an effective strategy is, if you go out and then it's maybe the family or the patient, you say, I'm really sorry this has happened to you. I'm still getting all the information together to understand why this happened to you. So can we have another meeting tomorrow? And I'll have a lot more facts. I'll be more than happy to answer all of your questions. And we go from there. So what you've done is you've given an apology, but you've also acknowledged that you need more information to be able to give them the full picture of what actually went wrong, or the full explanation of what went wrong. Also, in that interaction, you'll have a strong feeling of what actually the family or the patient expects. And if they start throwing a lot of questions and saying, oh, but why did that happen? Why wasn't it prevented? You can go, however you're speaking with that family. Sir, ma'am, Martin, I understand, I appreciate that you're upset. I fully understand this is a severe event. I don't have all the facts at my fingertips at the moment. I don't want to give you half information. I want to give you everything in a manner that you can understand it. I will come back to you. I promise you that. I'll meet you tomorrow and you give them a time. And that usually actually abates it. And as I say, that's usually, the more severe the adverse event, that's usually a good way of doing it, because you also need to go home and sleep on it and say, I mean, obviously the worst outcome that we talk about is a patient passes away while we're caring for them. You also need to be able to go home, have a beer or whatever it is, even though that wasn't felt very appropriate, but have a beer and sit down, a glass of wine, and just reflect, because that reflection is incredibly powerful. Because you also need to come to terms with it yourself, because you are the second victim, and you're managing your process, and you're managing the process of the family. So you need to manage your process first, because if you are not 100% understanding of what happened, you've come to terms with it, or not necessarily completely, but you understand, you've gone to terms, that takes time. That's not something that's going to happen within a few minutes after the event. So in other words, go home, sleep on it, the next morning have another think about it, and then go and have a meeting. And it also gives you an opportunity to make a few phone calls. If you have a mentor or a senior colleague, phone them up and say, this is what's just happened to me. What do you think I need to do? Or you phone your MPS or whoever you are with and say, this is what's gone wrong. How do I manage this? What do I say to the family? What do I write in the notes? What must I do going forward? And then that support will be there for you. What you should not do is just bottle it and keep it to yourself and try get out of that hospital, leopard crawl into the parking lot, crawl into your car, drive out, and then disappear. That's the worst thing you can do. What you really do need to do at that moment in time is really phone someone that you trust and say, this is what's going on. How do I manage it? And hear what their advice is.
Definitely noted, which then now brings another question. I don't know if you'll be able to answer. Yes, in private practice, well, I hope we all have insurance and we have people that we can call like MPS or whoever that's out there. But does this then not mean, for instance, in the state setting, shouldn't there be a psychologist or a counseling room available for doctors or all the healthcare workers after an adverse event or a death, whereby people can actually go and debrief? Because I have a personal experience which I think I'm still grappling with, and this happened donkeys years ago when I was still an intern. And I feel like, had there been that room or that opportunity to go and say to someone, this just happened to me, how do I deal with it myself? And how do I deal with the family? It would have made a difference in my life, because like it's crazy. I mean, you know how it is. When you are an intern, you are the first point of call. So if there's a recess, you are the first person called, and then you will call the MO or the reg, whoever you are working with, depending on the hospital. But you never know how long it will take before they get there. So sometimes by the time they get there, the horse was already bolted. Now, you as the intern now have to deal with that death. You must then write the death certificate, and you must then call the family and inform the family. But now, who counsels you? So, shouldn't there be such a thing available at hospitals?
Yeah. So again, it depends on where you are. I think in that instance, the first port of call has to be your immediate supervisor, and to say, look, this is what's going on. How do we manage? So at a level of intern, comserve, you're always working under supervision, and that person has to be the first one speaks to. If one doesn't get much support there, then the next step is there a head of clinical unit or is there a head of department, and go and have a word with them. I can say in the bigger hospitals, so like for example in Steve Biko where we are now, we do have measures in place for this. But the problem is that you actually do need people in leadership roles who are experienced and sensitive to this, and that realize, okay, in the handover meeting this morning, this death was presented. I can just imagine how bad it must have been for that intern. It's then going and finding that intern and saying, how are you? Are you okay? Do you want to talk about it? I know that was tough, what happened last night. So we need to, as leaders, also realize that one has to reach out. And that's why I was saying we have to actively reach out to our colleagues, be it in public or private. In the public sector, again, like I said, and I think there are a few models like that. With us, our psychiatry department is very open. We have a fantastic head of psychiatry who really actively encourages doctors to come and make use of their services if there are problems. And I think especially with COVID and everything else, that really came to the forefront. Our psychiatry department really was there. And I know at Barra, it's very similar, etc. So that does exist. And that is, but again, for the juniors, an intern might not be aware of that. Whereas we, as heads of units and departments, we are very much aware of Prof. Grobler and his services that he offers. And it's again, it's realizing and saying, okay, I can see you're not coping with this. And it might be one of your consultants. It's going to that person and saying, you know, Martin, I can see you're battling. How can we help you? Can we help you? Why don't you go and see Stephen? Let's go. And is there somebody who you want to go with you? Or if it's someone that I know very well, I'll say, I mean, I had this last year actually with one of my colleagues where unfortunately a patient passed away on the table that shouldn't have passed away. That surgeon took it phenomenally badly. And I went with him to Prof. Grobler, went with him. And for the first 2 sessions, I actually went along. And up until now, that consultant is still attending the support. But it's just picking that up and realizing, and unfortunately, we all have had adverse events. There's no doctor who can tell me they haven't had an adverse event, because then that doctor hasn't practiced medicine. We've all had them. We all know how difficult it was. And in my day, exactly the way you describe it, you had to deal with it yourself. And there was a stigma associated often with it. Our seniors would run away from the fact that they are actually the ones who have to phone the family to say, look, so unfortunately, I have bad news. Would you please come to the hospital? And that's what we need to change actively as leaders in our space, is to take away that stigma, but also to take away the responsibility from the junior doctors. It is not fair, it is not appropriate to allow our juniors to deal with that kind of stress. They have no experience of it. And I actually feel very strongly about that.
Yeah. Can I also just please chip in there? I mean, thank you for that. And I just assume that online there are private practitioners as well, not only people in hospitals or academic setting. And I mean, that is how the last part of my talk, the healthcare workers support group came about, was in COVID. When COVID happened and all the doctors were facing death and patients dying and unable to do things with patients, the psychiatry department at WITS started the healthcare workers helpline. And after COVID, we decided just to continue with it. And so they've handed it over to SADAG, which is a nationwide thing. So they offer that kind of service as well. So where people can, if you don't get help from your department, or you not feel comfortable to speak to people in your own department or your own hospital, there's a helpline available. So you can phone and you can speak to a professional counselor on the other side of the helpline, who will then also refer you to psychologists, clinical psychologists that deal with it. And then we've got the support group once a month as well, which is this Thursday evening. So, I mean, those are just extra things that to add to Prof. Brandt's thing there now, that, you know, to talk to your seniors and departments and Department of Psychiatry. So all of that is available. So, you know, we just, I suppose, get the message through to all our colleagues in state, academic, private, that these helplines, there is help, and please just don't keep it inside. And if you, not only with a death, but in stress, burnout, and all of that, to please make use of these facilities.
Well said, and thank you very much, Dr. Korb. I'm looking at the time now. It's 19:27. I think we're supposed to be running up until 19:30. But I don't see any more questions in the Q&A. I don't know if there's any further questions, but I think before we can actually close this session, I would really like to say thank you very much to the both of you, Dr. Korb and Prof. Brandt, for the presentations, and they were very much informative and very much welcome. To our members and non-members that are online and those that couldn't attend this, I think we will try and make this available so that we can spread the word. There's some very vital and crucial information that you've shared with us that I think it will be of disservice if we don't share it with everybody else, more especially with the support groups that are out there. I mean, I didn't know about some of these the helplines that are out there available to us as as healthcare workers. So I think if we make this available to everyone, it will really, really, really make a difference. And it will also help more especially with our juniors. They are the people in the front line, unfortunately, even though we don't want them to be the ones in the front line. And they're also not just grappling with their own mental health, it's also with the issue of being unemployed. Unfortunately, that's what's happening now to our junior doctors. So these support groups and helplines would really, really be of help to them. And I think with that, unless if there's anything anyone else would like to say, I would just like to express my gratitude and thank you. And we'll then with that, then close the session. Thank you very much.
Thank you very much.